Good evening, everyone. I am Ada from IJCP. I extend a warm welcome to all our esteemed doctors and speaker for today's session. Today's topic is a most important evolving area in obstetrics. Intrahepatic cholestasis reimagined from pathways to precision treatment. Intrahepatic cholestasis of pregnancy continues to challenge clinicians with its unpredictable nature and potential risks to both mother and fetus. With emerging insights into biochemical pathways and new precision based therapeutic approaches, it becomes essential for us to revisit this condition through a modern lens. And that is exactly what this session aims to deliver. It is my privilege to introduce our host for this evening, Dr. Sharda Jain, ma'am. She is the Senior Consultant Obstetrics Gynecology Director, Life Care Center and Life Care IVF, member of NMC Ethical Committee, Secretary General in DGF, and founder and chairman of the North India Gynecologist Forum. Dr. Jan is a leading voice in women's healthcare, and now I hand over the session to ma'am. Thank you so much, Dr. Sharda ma'am. You can proceed. Thank you.
Thank you very much, Ada. My lots of thanks to giving us this national platform. And the topic today is also very important. Intrahepatic cholestasis. It will be an update by Dr. Shashi Kabra, which is a senior gynecologist at the DDU hospital. She has been past president of Delhi Gynecologist Forum Southwest, and at the moment she is in charge of preventing the preventable mortality as far as North India Gynecologist Forum is concerned. She has been a very active person, and she will do a great job. This is her pet area, and we have two experts who are going to be with us. Dr. Kalpana Kumar is there, senior gynecologist at Swami Dayanand Hospital. She's one of a great teacher, and we have Dr. Samishta Garg. She is from Gangaram Hospital. She's secretary of Delhi Gynecologist Forum Central. So these are going to be experts, and their role will come after Shashi Kabra's presentation. Over to you, Dr. Shashi Kabra.
Thank you, ma'am, for such a kind introduction. Thank you. Please start my slide.
दिखा दो अदा. हेलो मैडम, आप कर लो दोबारा प्रेजेंटेशन.
Yes, ma'am.
Okay.
अदर स्लाइड्स दे दो इनकी.
No, it is not visible, ma'am. Please share screen, ma'am.
Yeah.
I cannot see.
मैडम दोबारा शेयर कर लो.
No, ma'am, it is not visible for me. I think ma'am is removed.
आप देखो क्या करोगे आप.
Ma'am is removed herself, ma'am.
दोबारा शेयर करेंगे.
Okay. Yeah.
Shashi,
Ma'am,
share please.
She is not here, ma'am. I think. Is there any issue? I need to check it. So you can explain about the topic, ma'am. Yeah, she is there.
Dr. Semishta, you want to say something? Yes, she's here.
Yeah. It is not showing share screen option now. Where is it?
मैडम, इसको सबसे राइट हैंड साइड में जाएंगे, एक क्रॉस जैसा बना है ना, इसको आप प्रेस करेंगे तो अब छोटा स्क्रीन हो जाएगा. आप करो, आप शेयर स्क्रीन है. डॉक्टर शशि.
Yes, ma'am.
Now you can do it. You can see.
No, ma'am. Ma'am, just click on a plus option, and after that you can see the share screen option.
ये जो प्लस ऑप्शन आ रहा है ना बॉटम में.
Yeah, I got it.
So I can add from there.
Yeah.
इसके बाद 2 बार शेयर स्क्रीन आएगा, तो वो करके फिर एंटायर स्क्रीन करके करो.
Right. I'm doing it.
Yeah, ma'am. Now I can see your screen.
Okay.
Just.
So I'm just making it slideshow.
Yeah. Ma'am, now it is visible. Keep it in a full view, ma'am. Yeah, ma'am. Perfect.
फुल स्क्रीन करो.
keep it in a full view.
मैडम नीचे जो एरो है ना, यहाँ पर, यहाँ इस पे करो, फुल स्क्रीन कर दो, दैट्स इट, बॉटम में.
Yeah, ma'am. Perfect. Thank you.
Okay.
Yes.
Yeah. So today's topic is intrahepatic cholestasis. Recently, we are getting a lot of patients with intrahepatic cholestasis. The other names for it is, in short, it is also called ICP, and the other names are recurrent jaundice of pregnancy or cholestatic hepatosis or icterus gravidarum. The incidence is from 1 to 27% in different parts of world, but in our country the incidence is increasing. It is already around 5 to 7%. Now the question is why it is so important to discuss this topic. So the condition is associated with a lot of fetal problems and a few maternal problems. So what are those fetal problems? Serious fetal complication is sudden intrauterine fetal demise, and that is not acceptable at all. Then preterm birth, it can be an induced preterm birth or a preterm birth spontaneous. Then it leads to a lot of meconium staining of amniotic fluid and consequences, and fetal distress of different types of patterns. In mother, it leads to severe pruritus, vitamin K deficiency, and even postpartum hemorrhage. And the disease is increasingly recognized and often underdiagnosed. Early identification improves maternal comfort and significantly reduces the risk of stillbirth and preterm birth. Awareness among clinicians help ensure timely bile acid testing and evidence-based management. The main investigation for this treatment is bile acid. It is not the enzymes, ALT or AST. And strengthening diagnosis and referral pathways can greatly improve perinatal outcome in our setting. Rather, I can say that it is almost, if we manage it properly, then it almost lead to zero stillbirth rate. So the diagnosis of ICP is when the value of random total bile acid is more than 19 macromole. And the commonest symptom is itching. Usually it occurs late in pregnancy. And the diagnosis is more likely if it is confirmed that itching and raised bile acids resolve after birth, because this is a pregnancy induced condition. So the definitive treatment of this condition is delivery. And those conditions which have been induced will resolve after pregnancy. Now, as I've already said, itching pruritus is the commonest sign. So what type of pruritus is this? It is a generalized pruritus. It has a special predilection for the palms and soles. Usually develop late in pregnancy, sometimes earlier. The earlier it develops, the worse the prognosis. Usually the constitutional symptoms are absent and skin changes are limited only to excoriations, and that happens because of scratching. Pruritus often intensifies at night, potentially resulting in insomnia, irritability, and even depression. Now, on the right hand side, you can see a picture. This is a woman admitted in my ward presently. At present, we are our 60% of beds are occupied with ICP patients, and I've taken her photograph. So you see here this rash. So it does not have any other character. The rash and the changes because of skin excoriations, that is very, very particular of this pruritus. So new onset pruritus in pregnant women, if associated with rash, it is unlikely to be ICP. It is not associated with rash. And if this itchy skin looks abnormal other than excoriation, then also we have to think of another cause. So the lesion in this case are only with excoriation effects, no other thing. Liver function tests and bile acids are usually not required routinely, but there is a pattern in our country that we first get AST and ALT then, and then we think that if it is high, then bile acid is to be done. But if the patient has pruritus, we should straightway go for bile acids. Clinicians should be aware, however, that skin conditions and ICP can coexist. So this pruritus caused by ICP does not result in a rash. However, severe itching can lead to prurigo nodularis, which may be diagnosed as a rash. So you have to differentiate between the two. It is necessary to exclude pruritus caused by other related diseases such as HIV, liver disease, chronic renal failure, pregnancy-related diseases, including polymorphic eruption of pregnancy, pruritic urticarial papules, plaques of pregnancy, and pemphigoid justanis. The most common pruritic condition in pregnancy is polymorphic eruption of pregnancy, which is associated with an eczematous rash on the face, eyelids, neck, anticubal fossa, popliteal fossa, trunk, and limb. So, though this is most common, but we have to differentiate it from that lesions, which happens because of ICP, and they do not have predilection as shown in these areas. Now, the course of the pruritus, within 4 weeks of the onset of pruritus, some ICP patient may develop mild jaundice. Remember the word mild jaundice. In fact, most of the time, icterus is not seen. It is not an infective hepatitis. The reported incidence varies from 10 to 25%, and the Society for Maternal Fetal Medicine suggests that jaundice is not common ICP, and patient may occasionally pass darkened urine or pale stools. But this is relatively rare and may indicate the presence of other liver diseases. So we are left with still only with the rash with changes due to excoriation. We are left with only with the lesions with changes of excoriation. The other less common symptoms include abdominal pain, nausea, vomiting, loss of appetite, staturia. The clinical symptoms of ICP will naturally subside within 1 to 3 weeks postpartum, which is a distinctive clinical feature of ICP. Biochemical tests may be abnormal at presentation or may follow initial pruritus after several weeks. A rise in transaminase level. Transaminase means AST, ALT. Nowadays, they are universally called as aminotransferase and alanine transferase, and they may precede an increase in serum bile acid levels. Approximately 10% of women have concurrent jaundice. Pathogenesis is unclear, but whatever Williams says that it may be due to changes in various sex steroid hormone levels. In one study, women treated with vaginal progesterone for preterm labor prophylaxis showed a fourfold increase in ICP rate. So we have to be careful when we use vaginal progesterone, and many mutations have been implicated. Of them, ABCB4 gene is also very significant. But anyway, we are not going into research. We basically will focus on the clinical aspects. This one more, farnesoid X receptor also induces drug-induced cholestasis and counting gravidas while taking azathioprine following renal transplantation. Following enzymatic cause, the bile acids are incompletely cleared and accumulate in plasma. Now coming to histopathology, liver biopsy shows mild cholestasis, inflammation, and these changes disappear after delivery but may recur in subsequent pregnancies. In fact, ICP recurs in pregnancy. So this was a cohort study of approximately 39,000 pregnant women, and it showed that there were a few high risk factors, and these are maternal age younger than 25 years or older than 35 years, low or high pre-pregnancy body mass index, hepatitis B surface antigen positive status, multiple pregnancy, low maternal education level, insufficient pregnancy weight gain, in vitro fertilization, history of cesarean delivery, history of 2 or more miscarriages. These all are associated with increased incidence of ICP. And besides this, there are other factors like gestational hypertension, preeclampsia, thrombocytopenia, hyperlipidemia, gestational diabetes mellitus, history of smoking, and women with a history of hepatobiliary diseases. So now how to prevent the disease? We know that this causes sudden stillbirth, so we have to screen the patient. The maternal fetal medicine guidelines says that in high prevalence area, we have to specially do the screening. But in our country, it is better nowadays. The amount of in the number of cases we are getting, I think that we should all at least screen every woman, especially those who had ICP in earlier pregnancy and with the high risk factors which I have mentioned. And we should provide them adequate prenatal education, provide prenatal care and assessment, monitor for abnormal blood pressure that we have been doing regularly, blood glucose and weight gain we have already been monitoring. So we should identify and control the high risk factors. The perinatal complications, I'm repeating second time, and I intentionally wanted to repeat it so that it just instills into everyone's mind. It may lead to fetal distress, Meconium stent amniotic fluid, stillbirth, preterm birth, both therapeutic and spontaneous. The incidence of stillbirth in ICP patients is significantly higher than in non-ICP patients. Brewers and colleagues in 2015 mentioned that higher rates of spontaneous birth reach up to 19%, and that of meconium stent like maybe up to 48 to 50%. Reports indicate that the rate of stillbirth that touches 7 weeks of gestation and beyond in ICP pregnancy is 0.1 to 0.3%. So we have to focus on this also. In fact, one study found that among 20 cases of stillbirth associated with ICP, the median gestational as death was 38 weeks, with only 2 cases occurring before 37 weeks. Spontaneous preterm birth tends to occur earlier in pregnant women with pruritus, and the incidence of a spontaneous preterm birth increases with the elevation of maternal serum total bile acid levels. Why does this preterm level occur? The cause is unclear, but one hypothesis says that deposition of bile acid in the uterine myometrium may contribute to increased uterine activity and onset of preterm labor. So far as mother is concerned, there are very minor complications, but the rates of labor induction and cesarean delivery in affected women increase. Now, recommendation. During antenatal checkup, women with ICP should be informed of related perinatal outcome, which may include stillbirth, preterm birth, meconium stent liquor, neonatal respiratory distress syndrome, and preeclampsia. And the guidelines recommends that the risk of stillbirth and preterm birth is related to the value of total bile acid, and when the value is more than 100 micromole per liter, the risk of stillbirth and preterm birth is significantly increased. And a lot of research have been done behind the cause of sudden death. In fact, the death is so sudden that even if 1 day earlier the biophysical score was normal and the non-stress test was normal, even then the baby can have sudden death. And the reason it is usually said that it leads to sudden arrhythmia of the fetus, and chorionic vasospasm obstructs the flow of oxygen-rich maternal blood to the developing fetus, which may lead to asphyxia, and the fetal death may be due to cardiotoxicity of these bile acids which are accumulated. So that is one of the major fears. And prolongation of fetal cardiac PR interval also occurs with this. Last and co-workers demonstrated impaired globular ventricular function in fetuses of pregnancies complicated by ICP. As a threshold for comparison, total serum bile acid typically remain less than 10 micromole per liter throughout normal pregnancy. So this is a chart which shows that gestational pruritus means itching and peak bile acid concentration. Here the value of the bile acid is less than 19, then mild itching and the value is between 19 and 39, moderate 40 to 99, and severe means more than 100. Peak bile acid concentrations refer to the highest bile acid concentration recorded during a woman's pregnancy. And the upper limit of normal bile acid concentration in pregnancy is 18 micromole per liter. If it is 19, it is in higher range. So this hyperbilirubinemia results from retention of conjugated pigment. Alkaline phosphatase levels are usually elevated, even more than normal for pregnancy. And serum transaminases levels are normal to moderately elevated, but seldom exceed 200 units. Here, this is the point where we can differentiate it with infective hepatitis, where they may go into the range of 500 to 1000. So this is a very beautiful chart and very concise chart taken from Williams, which shows the difference you see. In one condition is hyperemesis gravidarum, where the AST may be increased. Then comes our ICP. The onset is usually late. Hyperemesis is the onset is early. Main symptom are pruritus and jaundice. You see here AST level is less than 200 most of the time, and bilirubin is also between 1 to 5, not much higher. These patients usually do not have icterus. Creatinine levels are normal, hematological findings are normal, and bile acids are more than 10. Then this is one of the dangerous condition, AFLP, acute fatty liver pregnancy. Here you see the AST has increased. Then there is thrombocytopenia, DIC, and hypoglycemia. Very dangerous condition. Then comes HELP. which happens because of preeclampsia and gestational hypertensive disorder of pregnancy. Here also bilirubin is not much high, but it is associated usually with thrombocytopenia. So basically, practically, we get ICP, we get HELP, and we get infective hepatitis, viral hepatitis. So in viral hepatitis, the value of enzymes is 400 to 5,000, and usually they get icterus. Their bilirubin may rise up to 20-25, and the markers are positive. So if a patient comes, then we can easily differentiate that this patient is ICP because she will not have jaundice. Her values of AST will be less than 200 to 250, and she will not have thrombocytopenia or any other thing, no icterus. In HELP, we can get other sign of HELP like helmet cells, pseudocytes in peripheral blood smear, and high BP. These patients usually have normal BP, maybe have borderline high BP. So this is how we differentiate it. And this, I think everybody should take a screenshot of this chart. Very useful and informative. Sonography may be warranted to exclude cholelithiasis and biliary obstruction. Usually they may have. This is just an association of stillbirth. So the prevalence of stillbirth, you see, it increases with the severity of ICP. And clinicians should be aware that fetal ultrasound and cartography do not predict to prevent stillbirth in ICP. And that's a very important information I have already told. That even in 1 day or even in 3 hours before, it was normal and still stillbirth has occurred. So in a case of mild ICP, we just repeat the total bile acid level 1 to 3 weeks until delivery. And then severe and extremely severe ICP, we recheck every week. Now, coming to management. First, I will talk about the symptomatic management and the definitive management. Definitive management is definitely delivery. So, pruritus may be troublesome and it is thought to result from elevated serum bile acid concentrations. Antihistamines and topical emollients usually provide some relief. We usually tell our patient to use calamine lotion and nariyal ka tel laga lo. Now, I have to talk a little bit about cholestyramine. It lowers the absorption of fat-soluble vitamins. It may lead to vitamin K deficiency and fetal coagulopathy, and subsequent fetal intracranial hemorrhage and stillbirth have been reported. So, this should not be used. Currently, the most popular treatment is also deoxycholic acid, which relieves pruritus, reduces serum levels of bile salts and liver enzymes. Dose is 300 milligram capsules. It is available in 300 milligram capsules, 10 to 15 milligram per kg of maternal body weight daily, and it can be divided in 2 to 3 doses. This is a chart about how to give. You can take a screenshot of this also. This is how the dose is calculated. And till now, we used to know only about this management, ursocholic deoxycholic acid, but this maternal fetal medicine guideline has included one more medicine as adenosylmethionine, and they say that it enhances hormonal metabolite methylation and bile excretion by affecting the composition of fluidity and hepatocyte membrane. But this is not that commonly available presently, but showing promising results. So pruritus typically improves 2 to 3 weeks of ursodeoxycholic acid therapy. Uh, it reduces the risk of stillbirth but does not completely eliminate it. Other described treatments are therapeutic plasma exchange and rifampicin. And a randomized trial comparing ursodeoxycholic acid and rifampicin is underway, done by Australian and New Zealand Society. So this is the chart. Now, yeah, I'm coming to the summary almost. Pregnant women with itching, that means women with gestational pruritus. If skin abnormal, then we are ruling out ICP. Consider other diagnosis. If skin is normal and scratch marks are seen only, then we may think of bile acids and we can get liver function test and bile acid done. So the bile acid may be in 3 concentrations, mild, moderate, and severe. We take a structured history, we examine the patient, and other routine examination are also to be done. So one condition is gestational pruritus, where bile acid will be normal. Second condition where there will be mild in case, and then moderate and severe. So, if gestational provitus, there is no effect on stillbirth, no impact on preterm birth, and no impact on birth timing. If it is mild ICP, we weekly measure the levels of bile acid. Usually, it does not cause any effect on stillbirth. The preterm birth rate is 16%. And with severe, we have to again measure it mildly, weekly, and in severe case, weekly. And we have to, if the value is more than 40, then we have to be more conscious. So if the value is between 40 or up to 40, then the chances of stillbirth is little more and the chances of preterm birth is more. We consider birth by 38 to 39, and if it is severe, then the chances of stillbirth is very high and we may have to deliver by 35 to 36 weeks. I will come to elaborate on this also. So now what happens? If my pregnancy has not attained maturity, the pregnancy is below 36 weeks gestation, then how to manage? So the most crucial aspect of management is carefully balancing the timing of delivery with the fetal maturity while closely considering the rising bile acid levels and their effects. हमको एक ऐसा टाइम डिसाइड करना है जहाँ की पेशेंट को बाइल एसिड से ज़्यादा नुकसान नहीं हो, बच्चा मैच्योर निकले, and we time the delivery. That is the basic management of ICP. So, suppose below 36 weeks, my patient has ICP, then I will continue ursodeoxycholic acid. I will repeat LFT and bile acid every 1 to 2 weeks. The best method for having fetal movement is fetal movement monitoring kick count. As you know that BPS does not help and other investigation does not help, like non-stress test. And here no early delivery is required because ICP is mild. Then if the value is this, then again you are giving ursodeoxycholic acid, you are doing LFT and bile acids. We consider antenatal fetal surveillance, but its use is limited and delivery is recommended at 36 to 37 weeks. If the value is in the severe range, then again we are giving ursodeoxycholic acid, antenatal fetal surveillance. We plan delivery at 36 weeks. Some people plan delivery between 34 to 36 weeks. Suppose the value is 90 to 120, 150 like this. And before 37 weeks, we have to give steroids to every patient. And if any other condition coexists, then we also terminate the pregnancy early, like severe pruritus or ineffective drug treatment or continued deterioration of liver function or history of ICP leading to stillbirth before 36 weeks of gestation earlier. If the patient is giving such history, then we terminate this pregnancy also earlier. So if high bile acids appear very early before 34 to 35 weeks, we exclude other liver diseases. We give ursodeoxycholic acid. We do frequent monitoring and assess for worsening, and continue pregnancy until recommended gestation, unless there is refractory pruritus, bile acids rising, fetal compromise, or any other obstetric indication. One important point about ursodeoxycholic acid is that it improves symptoms but does not completely eliminate stillbirth. So you just try to understand this, that ursodeoxycholic acid will not prevent stillbirth. So for preventing stillbirth, you have to monitor with bile acids and you have to deliver the baby at the most timed delivery point. Vitamin K to be given in those women who have some prolonged cholestasis and coagulopathy. So this is the summary table, very easy to remember. And if the value is somewhere near 90, more towards 90, 100 and growing up to 120, we may reduce this to 34 weeks also. So if pregnancy is terminated before 37 weeks, steroid treatment is necessary to promote fetal lung maturity. Remember one thing, nowadays even RCOG guidelines says that we should give steroid up to 36 plus 6 days because this does not prevent it does not promote not only fetal lung maturity but prevents intraventricular hemorrhage and necrotizing enterocolitis. I always say that this 20 rupees injection saves 20,000 of nursing. So regarding postpartum, after delivery, maternal serum total bile acid concentration and liver function indicators should be assessed to determine whether pruritic symptoms and laboratory indicators have normalized, maximum by 6 weeks. If not, then the patient should be referred to hepatologist for evaluation of potential coexisting hepatobiliary diseases. So, this is the last slide of my talk today. And the source of this lecture is Intrahepatic Cholestasis of Pregnancy, guideline by RCOG, Clinical Management Guideline for Intrahepatic Cholestasis of Pregnancy, Maternal Fetal Medicine, and Williams, the great book. Thank you so much.
I think your presentation had been absolutely wonderful, very precise. And what you should remember is there are two things which are known for sudden stillbirth. One is gestational diabetes, another is intrahepatic cholestasis. We have two experts. So we will ask Dr. Shamishta Gar to make her comments, and then Kalpana Kumar.
Thank you, Shadajan ma'am, for giving me this opportunity. And this topic is something which is very close to my heart, ma'am.
Kalpana को भी ले
I
लीजिए. Yes, ma'am. Go ahead.
so, ma'am, this is one of the most leading and preventable cause of stillbirth. I would rather say, such a
Yes,
simple
yes.
diagnosis. Only one test, that is serum bile acid. That is all is required. The guidelines does not recommend any further test. If the bile acid is high, it does not recommend any further test, including the autoimmune panel and the viral hepatitis panel. It is not at all recommended. If the patient is responding to it, a simple medicine, ursodeoxycholic acid, is what we need. Second, no matter how much monitoring we do, but the patient awareness, the maternal fetal, I mean, the fetal kick counts is what the mother can tell us. That is the only thing which is going to help us. No biophysical profile, no amount of your Dopplers, nothing is going to help us, ma'am. We have had patients where the previous night the Dopplers were okay, and the morning the patient is coming with an IUD. So this is very disheartening to see, and this is very much preventable. So I think, ma'am, this is something, a high index of suspicion is what is needed in all the clinician. Always suspect IHCP in late second trimester or in early third trimester if the patient is complaining of pruritus. That is what we need to do. Now coming to, ma'am, I have only one discrepancy with what Dr. Shashilata Kabra ma'am has mentioned about the steroids, ma'am. We are not giving steroids beyond 34. RCOG and ACOG differ in that part of steroids. RCOG because NHS is conducting the deliveries in RCOG in Britain. So what they're doing is the midwives, they're taking the delivery, so they are trying to shift the baby to the nursery. So for them, prolonging or delaying their steroid till 36 plus 6 weeks is okay. But American College, what they are saying that when they observe these babies for like 2 years of their life, they have found a significant motor dysfunctions in these babies. So the pediatrician colleagues, who they have come up with a big banner now that don't give steroids beyond 34. So that is one
But
thing, ma'am, I think we need to. We are not giving steroids, ma'am, after 34, no
no,
matter
I,
what.
I totally agree with you that the steroids have to be
Hmm.
given between 24 to 34 weeks and
We
should
are
not
not
be
giving
given.
beyond that, ma'am. Because they have actually come up with so much of literature that they are causing motor impairment in the babies when they're following the babies for 5 years of age, ma'am. So that is one thing I would like to differ. Other than that, it was a very comprehensive lecture, ma'am. A message very well given. And I think we should make everyone aware of it. In fact, the patients also. We should ask leading patients, are you feeling any kind of itching, especially on the palms and sole? The patient comes, हाँ मैडम होती तो है, but हमें लगा जरूरत नहीं है बताने की आपको. Palms में तो होती है मुझे itching. And you get a bile acid done and you find it elevated. So I think the awareness is what is required, ma'am.
In
Thank you,
fact,
ma'am.
ma'am, I would like to just add one line in due course of time. We should advise one value of bile acid to every woman. Maybe.
Yeah, maybe one leading question, ma'am. One leading question. This is such a simple thing. One leading question. मैडम पेट पे तो होती थी तो हमें लगा कि वो आ रहे हैं स्ट्राइज आते हैं स्ट्रेच मार्क्स हैं तो हमें लगा हाथ में भी होती होगी so they never feel कि हाथ में itching is related to your pregnancy. So I think एक leading question, ma'am. Second trimester onwards, I think that should be enough.
Yes, yes, yes.
Dr. Kalpana is working in a tertiary care public hospital. Let us share
Swami
her
Dayanand.
experience.
Swami,
Dr. Kalpana.
I am working in Swami Dayanand Hospital. Dr. Shashi, congratulations. You have covered the all topics related to the subject and very good lecture. And what I want to tell that we should advise post non-fasting bile acid level. Not fasting bile acid level should not be done. So this message should also be given to the public that non-fasting bile acid level should be done. First thing this, and second thing that bile acid sometimes take some time to increase, and pruritus appears even earlier, sometime earlier
Yes,
than the bile acid
it
increases.
may
So
appear 4 weeks
a
earlier. Yeah.
Yes, so a repeated bile acid to be done after if patient does not have the this pruritus improvement. So we should start giving this Udilip tablet earlier, and we should keep on doing this bile acid level after weekly bile acid level. And patient should be known that most of the time it happens in late second trimester or early early the third trimester because of the hormonal issues. So, and especially in twin pregnancy also, and in IVF pregnancy also, the chances of pruritus and this obstetric cholestasis are more.
Yeah,
So
these are
these
high
are
risk
the risk
factors.
factors. Yes, you have told, so repeatedly we have to tell to the patient ki because of this reason she can have. And one more thing is that only bile acid sometimes it may be normal, but the pruritus, the obstetric cholestasis may be present. Even the bile acid is normal. There is one chemical which is known as lysophosphatided acid. This can cause the itching and obstetric cholestasis. And even if your bile acid is normal, so bile acid slightly having a limitation in diagnosing. So symptoms and clinical management should be done according to the symptoms also, and not depending entirely on the bile acid. Definitely guidelines are there, mild, moderate, severe, and we should go with that. But don't even underestimate if bile acid is normal. So keep this in mind, because sometimes we have seen the patient, we do not find any cause of stillbirth. So this may be a reason that patient is having some kind of chemical things in the bloodstream and can have this stillbirth. So
So
I think
I
this
think what
is good.
Shashi has said, whenever you find rash, when you find itching without
Yes,
rash, one thing is your आपके कान खड़े होने चाहिए. Bile
yes,
acid
yes.
is the diagnostic thing, and I think we in our practice also we have seen itching के बहुत देर
Yes.
बाद आपके bile acid rise होने लगते हैं. Patient
Hmm.
counseling is very very important. The stillbirth can be sudden, and any kind of an ultrasound CTG is not going to help us. Your movement assessment is going to make the difference. I just want, before we close, one tip from each one of you. Shashi Kabra, what is your tip? Dr. Shemishta and Dr. Kalpana.
Yeah, ma'am. First, may I request you one thing? Still, we have 12 minutes left. So I have
आप तो चले ही गए.
I think there is a power failure, ma'am.
Dr. Shamishna, बताइए.
Ma'am, high index of suspicion. High index of suspicion should be there in our mind when we are sitting in the practice. So I think that's it. If you're suspecting, then you will be able to diagnose it faster.
And you must also tell that you can be delivered early. It all depends upon this thing. And any person who has heard it in her vicinity, her friends having a stillbirth, and she wants a little early delivery, you should not insist कि नहीं नहीं अब तो इसको wait करेंगे. एक तो चीज
And
ये.
one
Recurrence के
simple
बारे में
leading
क्या?
question. Exactly, ma'am. One simple leading question. आपको itching होती है हाथों में, तलवों में, अपने आप patient बताता है, ma'am. बस.
और recurrence के
Patient
बारे
are
में भी
very,
बताना.
in fact patients are very aware now. Patients are telling their symptoms very nicely कि बहुत खुजली होती है. They are intolerant. They tell spontaneously without even asking what happens with me. They are telling. तो ये तो है. और patient को यही बताना है कि मतलब incidents are increasing, and whenever you are taking a decision for delivery, the shared responsibility is to be taken, that this is your level, and with this much of level you can have more chances of stillbirth. So सारा pros and cons patient को समझा के उसके बाद we should
एक
take a
क्वेश्चन आप
decision.
दोनों से एक क्वेश्चन आप दोनों से. Do these patients have increased chances of postpartum hemorrhage?
Yes, ma'am. They do have. The patients are very
They
oozy.
do have.
They're definitely
They
oozy,
do
ma'am.
have
So we give prophylactic vitamin K. In all these patients, we are
vitamin
giving
K. Yes.
prophylactic vitamin K and tranexamic acid, ma'am. I think these two
Correct.
things really help
So
us a lot.
this is what we exactly do. We give tranexamic acid in such cases
Yes,
prophylactically, and
prophylactically
vitamin
before
C.
giving the
It's
And
incision,
not
before
even in the
giving the
book,
and
but
incision.
we give it.
and
Yes.
vitamin K and tranexamic acid should be given in labor. मतलब just
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 in
before the
cases of
delivery,
cesarean, ma'am,
just
in
delivery of
cases
the
of
delivery.
cesarean, 30 minutes before giving the
Yes,
incision. In case
yes,
of delivery, like once the patient is fully dilated, we start with that injection. And once the patient delivers, ma'am, it has nicely worked. The minute of, I mean, the timing of action is
Yes.
hardly 15 to 20 minutes. So I think
So
it's perfect for us, ma'am.
I'm glad three of us are on the same page.
Thank you, ma'am.
yes.
Thank you.
Thank you
So
so
thank
much,
you very
ma'am.
much. We wind it up.
Thank you
It
so
has been
much
a
for giving this
wonderful
opportunity, ma'am.
presentation. And intrahepatic cholestasis must be always remembered for sudden stillbirth. I think,
Yes, ma'am.
Dr. Shashi is coming. Let her make any
Hello.
comment in case if she wishes. Come, come.
Hello. Hello. Yes, my
Shashi, your last minute. Our comments are over.
connection is
Last tip.
on. I'm sorry. Yeah, yeah.
Last tip.
But my comment
Dr.
is
Shashi
this, that the
conclude.
incidence is increasing.
Increasing.
Am I audible?
Yes,
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 ma'am.
yes.
We
you're
can
right.
hear you.
Am I audible? Yeah. So I could not listen to others' comments because my internet connection went off. But what I want to say is that the incidence is increasing. We are getting a lot of patients. We should be aware about the incidence of this disease. We should not disregard the disease. And in every case, uh, our achievement should be nil stillbirth rate for ICU.
And
We
one
discussed in your absence, we discussed about have you found any increased incidence of postpartum hemorrhage, and both of my colleagues also agreed on the same. And so I think the discussion is over. So,
Ma'am, the incidence is not very high, but theoretically there is a risk and it has been mentioned in books. But
not
otherwise, we do
theoretically,
not see lots of
our
serious
experience
injuries.
shows that it
Yeah.
is there. I always
Yes,
see to
ma'am.
it that the blood is available in such patients. Okay. So
yes.
thank you very much,
Thank you,
and
Yes,
ma'am.
yes.
we come back again with the same
Huh.
team. Thank you
Thank
very
you,
much.
thank you,
Thank you.
Thank you
thank
very
you,
much.
thank you.
Welcome.
Thank you. Thank you.
Ada, there are no questions. Thank you very much
Yeah.
to your platform
Ma'am,
that we are
Ma'am,
reaching.
I had made a few MCQs. I have few MCQs. If everybody is interested, I can share those MCQs.
एमसीक्यूज आप करोगे तो फिर आंसर भी आप ही को देना पड़ेगा.
मैं ही बताऊंगी, बिल्कुल बताऊंगी.
हाँ बताइए.
यदि इंटरेस्टेड है लोग तो मैं बताऊं.
हाँ हाँ जरूर.
Sure, ma'am.
मैम
नॉलेज इज मेंट
मैं
फॉर
दोबारा
शेयरिंग.
रिकनेक्ट करती हूँ.
I will
लैपटॉप
also
से
guess,
दोबारा
ma'am.
रिकनेक्ट करती हूँ. Okay, okay, okay. So let me connect from laptop. Just give me time. At present, I am connected with phone.
मैडम इज कमिंग.
Yes, ma'am. We have to wait.
अब मैडम गायब हो गई तो लेट्स. मैडम लेट्स वाइंड अप. थैंक यू.
Ma'am, shall I
लेट्स वाइंड.
conclude? Okay.
यस.
Okay, thank you so much, Dr. Shadaja and Dr. Shashilata and Dr. Kabra Maheshwari, for your time and expertise and valuable insights. Thank you once again. Wishing you a wonderful evening. Stay safe, stay connected with IJCP. Thank you.
Thank you. Thank you very much.